Okay, hello, welcome everybody. So I'm Amanda Jones, and this is a presentation on disability justice. So it's looking at lived experience and just transition. So, little introduction. So, what we often forget about with disability is that the world is very inaccessible. And here in this presentation, we're going to explore lived experience, intersectionality, so how different bits of lived experience link to each other, like privilege and caring, inclusive events, resources. We've also got some social influencers and how it all relates to climate justice. So it's about looking at how we can all work in equity. Equity is when there's a lovely example given recently with cycling accessibility. So if you were looking at equality cycling, everyone would be on the same bike. Children would be struggling because the bike would be too big, but the bikes are all equal. So we're providing the same bike to the whole group of people, which means that it's equality. And then, of course, people in wheelchairs can't get on the bike, so they're excluded. And then you've got all sorts of different things. Equity means that you're coming together as you are. So you're meeting people where they're at. So it might mean that, for example, someone who can't use their legs uses a hand cycle. And that then gives all sorts of different bikes, which enables everybody to take part in cycling. So and then it enables accessibility. So I thought that was a lovely example of equity recently. So I could talk about my lived experience. I do a lot of patient advocacy work across the country, and the reason I do that is for awareness and to support and help other people. So I know that I was always encouraged to speak up, get my voice heard from hearing about what other people had overcome and lived and adapted to, just making sense of my life and knowing that I was okay where I was. It didn't matter where I was in my life. And just, exploring how I could live, with a quality of life with different things that are, wrong with my health and also from different privileges as well. So this is a little bit about my experience. So leading up to diagnosis, there was certain problems, and then there's things which become into joined up care, into this column over here, holistic thinking, which then show how working together has enabled positive response. But you have to do one to link to the other. So leading to diagnosis, a lot of pain is ignored and symptoms ignored. Misdiagnosis, especially with women, there's this sort of hysteria sort of remnant from the Victorian age. So there's a lot of work that's been done around inequality in women and people who identify as women because they're sort of told that their pain is in your head, or it's normal, it's natural to be in pain because of being a woman. That does more damage, it traumatizes you. And actually, because that misdiagnosis is a label of anxiety, you actually then get frightened to go back to the doctor. So the doctor's actually caused anxiety. And it can get even like PTSD because you're frightened to seek help and you know there's something wrong, but you struggle to get validation and diagnosis. But then when you do get that, I was then diagnosed with all these different things. So it's this course of my life, which I'll show in a sort of chart shortly. But so I was fainting a lot, took years and years. That's through my childhood. I was eventually diagnosed with a thing called coronary artery spasm. So that involves my heart, and it means that the artery in my heart goes into spasm and it cuts off the blood supply and makes you faint, gives you sort of angina-like pain. After a battle of many years, I got that diagnosed with an angiogram. So it was a long process. Endometriosis, I was crippled by my periods as soon as I started them, which was age 10. And I literally couldn't move. I missed a lot of school. Every 3 weeks, I was off for 3 to 4 days and I couldn't get out of bed. I couldn't eat. I had all sorts of problems with my tummy, upset tummy, and I was sick and all these different systemic things, which was eventually diagnosed 18 years later as endometriosis. A lot of that inequality there comes from being a child. There's a lot more recognition now that things do affect children. A lot of research going into endometriosis. What it is when the lining of the womb grows outside the womb. So it goes on the inside of your body. So it could be like little sort of lesions which grow and get bigger and they stick to the outside of your womb, outside of your ovaries, your bowel, your bladder. There's a little bit around the back called the cul-de-sac. It all sticks everything together. So, when you have your period, you bleed. When these endometriosis lesions are activated by your hormones, they produce scar tissue. It's a natural response to trauma in the body, inflammation. So it's creates like a cling film effect. It pulls things out of place. Pulled my ovary around my back and twisted it. And I was still told it was all in my head. I was actually unconscious sometimes. So, and eventually they found out that it was endometriosis for doing a laparoscopy, which is it's a minor operation, but they have to look inside your tummy with a camera and then they can diagnose it. There's a lot of work going into it. 1 in 10 women have it. So, it's well behind the time that it should be in the world. So it's one of those inequities that's being addressed. Eventually, I had a hysterectomy after treatment and hormones and things. That doesn't cure it, and but it's obviously stopped my period. But I've now got my bowel, which is twisted out of place with adhesions. So it's caused something called cecal volvulus, which is this bit down the bottom here. And it's basically my appendix, and that area is up on the upper left of my body rather than the lower right. And the sort of function of your bowel is where you've got a muscle layer in between your intestine, which is called a mesentery, and it's actually wrapped, my bowel's wrapped around that and twisted. So I'm at a high risk of bowel obstruction. So I have to keep that managed. They can't operate because I wouldn't survive the operation. That's the main thing. So because I've got other things. So in the middle of hormone treatment, I started getting a lot of joint pain, and I had those symptoms for around about 8 years. I'd sort of always had problems with my joints, but since being a child, but it got a lot worse, a lot more painful. My ears were going red and sore. And then eventually I was diagnosed with relapsing polychondritis, and that's with seronegative rheumatoid arthritis. A lot of common things around rheumatoid arthritis are blood test results which have a positive indication. With seronegative rheumatoid arthritis, you get perhaps swelling, and which I was getting with fingers and my toes, things like that, but you don't get anything in your blood. So it's not something that shows up on test results, which makes it harder to diagnose. And RP, a relapsing polychondritis, is very rare. Currently, I think it's 3.5 in a million people have it. So it's people who have it like generally get to know each other because there's not many of us. We've got to set up a UK charity. me and two other patients, to help other people. That destroys the cartilage in your body, attacks it, causes inflammation. Hence, it was in my ears because that's cartilage, but not on the lobe. And then it's attacked my trachea and bronchi. So it means that my trachea doesn't hold its shape. It's gone all floppy because the cartilage structure is not there anymore. So I have to have treatment for that. And then I'm looking at sort of all of these things. So relapsing polychondritis is they've all got long, complicated names. We have a discussion about that in the rare disease community. And the other one, tracheobronchomalacia. So that's my breathing problem. And Siegel vulvis, they're all rare diseases. And then you've got the autoimmune common disease of rheumatoid arthritis and endometriosis. So you've got a mixture of living with rare disease and common, and that's an overlapping thing. And then with all of that, the treatment at the moment is, I think I'm nearly up to 50, not 50 tablets a day. There's this polypharmacy, they call it in medical terms. So you've got all of these different medications that you've got to absorb and digest and cope with, which all interact with each other. So you've got side effects, which create more side effects. So there's a whole web of things that you have to manage. Holistic thinking is looking at all of that sort of picture, if you like, of my lived experience and my health as a joined up person rather than an individual symptom. So I recently did a talk with Exeter University year one medical students, and we talked about it in terms of looking at how joint pain may link to breathing trouble, may link to ears being red. That all links to a certain disease. But if you're looking at it in a singular way, then it breaks it all up, makes it all more difficult to diagnose. And then that also links with shared decision making. So my rare disease is looked after mainly with specialists in London, and having a shared decision means that they will communicate with my GP and local hospitals, and that is something which isn't working so well at the moment. So we're trying to improve that, both with my work, where I'm working with Exeter and Plymouth, but also generally, nationally, looking at holistic thinking, looking at that personalised care. So one of the things with that is looking at mental health, looking at how chronic pain can have an effect on your mental health. It's not right that for example, I was 8 years in really horrible pain and I wasn't prescribed any pain relief. I wasn't given any support until I had the diagnosis. And then all of a sudden, I was told, yeah, that disease means you're in a lot of pain. Let's help you and give you pain relief. But what about the 8 years before that? It increases mental health problems, it causes mental health crisis. So it's a really important thing to recognise and work with, which we're doing nationally. And personalised care is what matters to you. You're looking at choice and control. You're working with your medical team. You're making decisions together rather than being told you should do this. Social prescribing fits in with that. Like going to respiratory choirs, for example, singing groups, all sorts of things like that. And then that empowers the whole team, and you're part of that team. And then that fits in with attitude of active listening, letters that actually reflect the appointment discussion. That's the thing that comes up. And things that are linking your notes together so that it's joined up thinking all around, and inclusivity. So that was a big thing about my lived experience. On this, it summarizes that as a picture, a sort of flow chart. And what I've done is I've highlighted in yellow every time I've been told it's anxiety and it's in my head. I'm imagining it. So if you look at the white boxes, that's my age, if you like. Well, it should be like a ladder. So you're sort of, you're coming down here and then you're coming down here and then you come down here. But with all these hiccups, it's not, it's all fragmented. And even now, all those years later, I'm still being told I've got anxiety when people don't listen. So that's where we need improvements. So it's sort of pain points, if you like, they call them touch points, pain points, where it's had a really big impact on your life. This is all going to be available so people can have a look at it later. So no worries. So looking and thinking about that, I put some words together and I thought that these could be grown upon, used in perhaps a game or a session where you think about how personalized care fits in with your health and your own lived experience, things like that. So that's just a few highlights and ideas. And then I've put some quotes into the presentation, which are all things that I've either heard or things that have popped up in different work-related things. So this one, don't judge a disability by its visibility. Like you can only see my head here, so you can't see that I'm disabled at all. And you just don't know what's going on with anybody, and it's all about being kind. This is an example of how it has an impact on your everyday life. So there's so much organizing, it's just constant. It's because things aren't joined up. I've got an example recently with my repeat prescription. I've got new medication which isn't on there, which means I've got to try and communicate that to my GP, and had to type it in that it's not on my repeat prescription, and I can't really tell whether I'm going to get that in my next repeat prescription until I collect it, because there's no way of saying thank you or yes, this has happened, so you've got this constant sort of thing where you're organizing and doing all this admin behind the scenes, as well as working and trying to live your life. So there's some examples there. It takes so long to fill the dossier boxes up. You can imagine with 50 tablets a day, it's if I had dementia or something like I wouldn't be able to manage, you'd have to have a personal carer to do that for you. I can't get that done. Sometimes you get the pharmacy to do it or stuff like that because I'm on controlled medication. I have to do something every month. So you have to do it yourself every month. Which is based on steroids. I'm on permanent steroids. So then you have to follow up on medical requests. I'm trying to get a local referral to a local hospital, so that's ongoing at the moment. And follow-up appointments, you often have no reply if you email, no reply if you phone, and then you have to repeat it until eventually you get through, and it takes just so much time. Contacting people for equipment. I've got a bath lift, for example. I phoned up because I hadn't had it serviced, and I thought, well, that's a bit funny. I think that should have been serviced by now. And so I phoned him up and they said, "Oh, you don't have a bath lift." I do have a bath lift. It's here. It's in my house, And I said, "I've got the receipt." I had to actually find the paperwork that I had when they installed it and send it to them to prove that I had it. And so it shows you how things can be lost. And then it got sent around the whole county through different departments, and I was the one who had to chase and sort it out. And anything that you own yourself, like I've got a stair lift, that's mine. I have to do that myself, and it all comes out of my own finances. And repairs come out of it. You've got that constant sort of thing. These are some pain points that I've been told over my life, which have stuck with me, and it's quite frightening. You'll always be in pain. What the doctor telling you that is just heartbreaking, especially when you're going to have something done to hopefully help your quality of life. If you're going to say something like that to a patient, you need to follow it up with how we can manage the pain. How can we help you, live? Because it does the opposite. You're wasting our time. So many times I've been told that of turning up in A&E. I've always go through GP or 111, and I'm told I'm wasting their time. You shouldn't be here. They're all things I hear time and time again, and it is devastating. Repeated hospital experiences that I've had, I've soiled myself, and I've just been left on myself, disabled, in pain, with a fever, with no help, and being expected to clean myself, and I just couldn't do it. And that is just so embarrassing. It's just completely wrong. Left in severe pain for 8 hours or more. Often when you're taken in an ambulance, you're told they can't give you any pain relief. So I've probably had my pain relief, which I have regularly throughout the day and the night to avoid being in excruciating pain. When you get admitted to hospital, that all goes out the window, and you have to justify, all the while, please can I have my pain relief? I'm in a lot of pain. And it takes hours. Left on your bed alone, can't get up because I come in an ambulance, haven't got my wheelchair with me. I haven't got the ability to care for myself. I can't be independent, and they haven't given me the call alarm. I've been in situations where I've had sickness and diarrhea and had to call for a consultant, and they're walking past to pass me the sick bowl. It's just not on. But I'm working on that, and the London hospitals are amazing. So looking at other things which have sort of brought me to where I am now, I was a young carer for my mum. That's my mum and me. She died 20 years ago. So I cared for her throughout my childhood. From the age I could walk and talk, I was called an ambulance when I was 3. I knew how to inject her. She had type 1 diabetes when I was that age and stuff. I washed her, I dressed her, I made the dinner with her, all these things that you do when you're a young carer as well as going to school. So I really dedicated my life to her. I wouldn't change it for the world, but it did make me vulnerable. I didn't know how to love myself, and I was socially isolated. So I've learnt that as I've, grown in my life, and met other people, wonderful people in my life. And I didn't even know I was a carer then. It was just love. But what that did was it taught me loads of practical skills. You're constantly adapting to things when you're disabled, trying to find other ways to do things. And empathy. I'm very empathetic because of that. So then looking overall at inequalities and how it affects the wider population, I've put this little slide together where it sort of looks at common inequalities. So my childhood was full of bullying. We were poor, we were vulnerable and isolated, and my own health prevented my career. So it involves difficulties in your workplace, especially this is going back in the sort of late 90s, early 2000s. You were very judged if you were a woman and you had women's problems, for example, which then aggravated your career. I trained in graphic design and got distinction from the London College of Printing, and I've actually kept that up throughout my whole life because I've worked in graphic design since then, alongside my other work. But I had to turn down a top career in London because of my undiagnosed endometriosis at that time. So I basically had to say to this wonderful man who was offering me this job that I was off in pain 3 to 4 days a month, so I couldn't commit, and that was accepted as normal. That it, then and that I couldn't do the job. So also, you're looking at the culture through the years. I grew up with the supermodel industry and body images and prejudice and stuff. It's all sort of interwoven together. And I learned how to mask my pain so that I could work and not be fired. So it was it's a different sort of culture than it is now. Young people are often told that, you have growing pains and you're too young to be sick, which we touched on earlier. And that's the sort of culture that is now changing. So, let's encourage this change. Let's help, people who are dealing with these issues get somewhere, follow their careers, work flexibly and, allow for disability. If you want disabled people to work, you need to allow a slower pace and you need to look after their health requirements. So, there could be many hospital appointments and there could be time off sick. And that's traditionally been when you've lost your job. So that needs to be looked at as an equity thing if you're disabled or you've got chronic illness or, anything that's affecting your health. So I've got two questions there which could be used in a further discussion. How does women's health affect society today? What is the history of hysteria? And why does that still, have an impact now? How do marginalised groups experience inequity when they're disabled? So that moves on to the next bit. So that's looking at how do different groups affect being disabled? So intersectionality combines all of our different personal protected characteristics, and these are some of the categories. So how do these different groups affect being disabled? It's like a discussion point, and we can have a little look at a video. These are some other categories of sort of marginalised protective characteristic groups that we can consider when we're thinking about intersectionality and how different groups affect disability. And then I've put together a few resources. So there's like things around event accessibility, which we've had a good look at with the Just Transition circle, which is part of Transition Together. So here there's some sort of highlights of what you can look at to enable it to be inclusive. And it links to this beginner's guide to event accessibility. And then there's a link here to the Welcoming Event Toolkit, which we've done with Just Transition and Social Justice. Here are some stories of different people that are sharing their own lived experience and ways that you can have a look at to look at race and disability and all sorts of things. So this is a common quote. I can't access it because I'm disabled. Well, actually, they know the problems are the barriers to me. So I might decide I can't get in a venue and it's my problem because I'm in a wheelchair because there's steps. And that's what the disabled person carries, when actually it's the venue that is the barrier, not you. So that's an important sort of thing to remember to help with everything. Here are some other resources. So I've included some social influencers because they're the people who are sharing their lives very visibly. They've got all sorts of tips around all sorts of different things. You've got doctors, you've got different people from different cultural backgrounds sharing their opinions. It's really, really helpful to be able to engage with them. And then recently, to show how society is, adapting and improving, you've got these laws that have come into effect recently. So these are sort of papers that have been published. So you've got people here looking at sociological methods and how practices can be put into communities to help accessibility and diversity. You've got a specific thing around young people with ostomy, and then there's a few links here about endometriosis, relapsing polychondritis, and rare diseases from my lived experience. And then these are the new rules. So you've got Jesse's rule, which was only recently introduced, which is a safety initiative. So much like me, people go back and forth all the while with the same problem, and they're told that there's nothing wrong. And unfortunately, Jessica died because it was a delayed cancer diagnosis. So now there's a rule, which means if you go back 3 times, the doctor needs to rethink it. And then Martha's rule is about the support around the early detection of sepsis. I had sepsis as part of my sort of infection when I was under treatment. So, it's a really important rule that's just come into place. How, overall society and culture affects us, climate change and disability is a really big thing. I put an example here about vulnerability. When my electric went off, I had to wait till 2 in the morning to get generator before I could get to bed and settle because my breathing machine needed power. And then I've got lots of meds in the fridge which, need to keep cool and all sorts of different things. Stair lift runs on electric. Everything, relies on the different resources that would be threatened and are being threatened with climate change. The Climate and Disability Bristol Climate and Nature Partnership have done an amazing resource, and it's well worth looking at it. And it talks about all these different things, and also about accessibility with public transport and mobility. So I've done a lot of sort of accessibility assessments, and one of the common things that you hear is we are accessible, wheelchairs get up the big step, okay. Practicalities and disability is sort of comes with frustration and guilt because you're aware of perhaps how you used to be, and now that you can't do it any longer the way that you used to. So you've got to be constantly adapting. And it's amazing what you come across. You've got this sort of map in your head as a wheelchair user of where all the drop curbs are and where the pavements tip you on cambers, all sorts of things, so that you get to know where you can travel easiest. And it brings a sense of guilt because you're riding this sort of wave of grief, which I talk about quite a lot in different settings. So you've got to constantly get on and off this wave of grief because you're battling different problems as they come along. And then as you accept them, you come back up to acceptance and appreciation and adapt to a new way of quality of life. So summary is that this resource is for education, empowerment and equity. And it's here as an open source resource so that you can put your own story into it. Can you adapt it for you? Can you work together? So that we can all reach equality. And that's me. Thank you. And that's my links. Thank you very much.